Our second speaker for the symposium is Dr. Peter Correa, MBBS, MD, DNB, MRCP, FRCR, and he is a consultant clinical oncologist presently based at University Hospitals Coventry and Warwickshire NHS Trust, UK. Dr. Correa specializes in the non-surgical treatment of gastrointestinal cancers with chemotherapy, radiotherapy, and targeted biological treatment. He undertook training in oncology in India at the Tata Memorial Hospital, Bombay. He acquired regional and national postgraduate qualifications in radiation oncology. He was awarded the Satyapal Agrawal Gold Medal for ranking first in India at the National Higher Specialist Examination. Dr. Correa is also a member of the Royal College of Radiologists, Royal College of Physicians, and the British Medical Association. Over to you, Dr. Correa.
Good morning, everyone. My name is Dr. Peter Correa. I'm a consultant clinical oncologist working at University Hospitals Coventry and Warwickshire, NHS Trust in the UK. I'm grateful to the organizers of this meeting for giving me an opportunity to talk about total neoadjuvant therapy for rectal cancer, an exciting and emerging new area of treatment. Here are my disclosures. I'm going to be talking about total neoadjuvant treatment for rectal cancer under the following headings. I'll first talk about the standard treatment of locally advanced rectal cancer. I'll then talk about what is total neoadjuvant treatment. I'll talk about why we should consider total neoadjuvant treatment, the evidence for total neoadjuvant treatment, the pros and cons of this approach, the challenges to its implementation, and I will look ahead to opportunities that this particular treatment option presents. So what is locally advanced rectal cancer? It is rectal adenocarcinoma that involves the circumferential resection margin. So it could be a T3 tumor with involvement of the circumferential resection margin, a T4 primary tumor involving one of the adjacent organs, or the peritoneal reflection in the upper rectum, N2 nodal status, that is involvement of 4 or more lymph nodes, lateral lymph node involvement, that is involvement of lymph nodes outside the standard resection field, and tumors with obvious extramural vascular invasion on diagnostic MRI. The standard treatment of locally advanced rectal cancer involves the use of chemoradiotherapy. The radiotherapy is 45 to 54 gray with conventional fractionation using either 3D CRT, IMRT, or VMAT with concomitant capecitabine or infusional 5-fluorouracil chemotherapy, followed after 8 to 12 weeks by total mesorectal excision surgery, and after recovery, consideration of adjuvant chemotherapy with either Capox or Folfox for 6 months. What is total neoadjuvant treatment? It is the use of pelvic radiotherapy and systemic chemotherapy prior to radical surgery. The radiotherapy could either be short course, that is 25 gray in 5 fractions, or long course, which is 45 to 54 gray with concomitant capecitabine or infusional 5-fluorouracil. There are different approaches to the chemotherapy in total neoadjuvant treatment. It could either be induction chemotherapy, where systemic chemotherapy is given before either short course radiotherapy or chemoradiotherapy, or consolidation approaches where chemoradiotherapy or short course radiotherapy is given first. So why should we consider total neoadjuvant treatment? Our current treatment approach has resulted in improved local disease control. This has also been improved by better surgical techniques, total mesorectal excision, which was pioneered at the Royal Marsden Hospital in the 1990s, and followed more recently by other developments, including use of laparoscopy and the surgical robot more recently. Also, better radiotherapy has been implemented. At our center, we use IMRT and VMAT as standard with daily image guidance with cone beam CTs. Unfortunately, overall survival has remained unchanged, with patients dying due to distant metastases by and large. There's also poor compliance with adjuvant chemotherapy after radical surgery. Patients might recover slowly, and that might result in either delays or non-application of chemotherapy. There's also poor tolerance of chemotherapy after major surgery, and the evidence for adjuvant chemotherapy is still weak. Finally, the most exciting possibility is the opportunity to consider organ preservation, which is of extreme importance to many of our patients. So what is the evidence for total neoadjuvant treatment? Well, the evidence was fairly sparse until quite recently, when at this year's virtual ASCO meeting, there were 3 presentations in the same session on colorectal and lower GI cancers, which covered the topic of total neoadjuvant treatment. These included the Rapido trial, the Prodige 23 trial, and the OPERA trial. I'm going to cover each of these trials systematically and try and give you a flavor for the results. So first and foremost, the Rapido trial. It's a phase 3 randomized trial, a large phase 3 trial with 920 patients randomized between standard treatment, which I described before, with chemoradiotherapy followed by radical surgery, followed by adjuvant chemotherapy for 6 months, versus an experimental approach which included the consolidation chemotherapy sequencing of total neoadjuvant treatment. Patients were given short course radiotherapy, 25 gray and 5 fractions, followed by chemotherapy for 4.5 months with either Capox or Folfox, followed by radical surgery. No adjuvant chemotherapy was given in this trial. The main results of the trial are as follows. The primary endpoint was slightly unusual. It was disease-related treatment failure. At 3 years, there were more treatment failures in the standard arm, 30.4%, versus 23.7% in the experimental arm. The hazard ratio was 0.75, and the p-value was statistically significant. The other relevant results are also very important. There were fewer distant metastases at 3 years in the experimental arm, 20% versus 26.8% in the standard arm. The p-value was significant. Overall survival data is relatively immature, but is the same in both arms. Very excitingly, pathological complete response rate was much higher in the experimental arm at 28.4% versus 14.3% in the standard arm. R0 resection rates were similar. Surgical complications were similar. However, there were more anastomotic leaks numerically in the experimental arm. This was not significant. And most importantly, the quality of life in both arms was similar. The Prodige trial is another phase 3 randomized trial with 461 patients. This is a French trial. Once again, the standard approach was what I described at the outset, with chemoradiotherapy followed by surgery, followed by adjuvant chemotherapy. In the standard arm, the experimental arm, they used an induction chemotherapy approach with FOLFIRINOX chemotherapy, which was modified. This is the FOLFIRINOX regime that is used in pancreatic cancer, but the modification was that they did not give bolus 5-fluorouracil, followed by chemoradiotherapy, followed by surgery, followed by the consideration of adjuvant chemotherapy for a total of 3 months. The median follow-up in this trial is 46.5 months, which is a little longer than the Rapido trial. The primary endpoint in the Prodige trial was a more conventional standard endpoint where 3-year disease-free survival was reported, and this was improved in the experimental arm from 68.5% in the standard arm to 75.7% in the experimental arm. The hazard ratio was 0.69 and the p-value statistically significant. The other relevant results from the PRODIGE trial include the 3-year metastases-free survival. This was also improved in the experimental arm from 71.7% in the standard arm to 78.8% in the experimental arm. The hazard ratio was 0.64 and the confidence intervals do not cross 1, suggesting statistical significance. The 3-year overall survival was similar but slightly better in the experimental arm. Once again, very excitingly, the pathological complete response was improved from 11.7% in the standard arm to 27.5% in the experimental arm, and reassuringly, the surgical complications were similar. The OPERA trial is an organ preservation trial which was conducted at the Memorial Sloan Kettering Cancer Center in the United States. This trial randomized between 2 neoadjuvant approaches. It included patients with stage 2 and 3 rectal cancer, so patients had slightly earlier cancers than the other 2 trials which I've already mentioned. There were 324 patients randomized. The median follow-up is quite short at 25 months. In arm 1, they used an induction chemotherapy approach where chemotherapy was given before chemoradiotherapy. And in arm 2, chemoradiotherapy was given first, followed by consolidation chemotherapy. The chemotherapy was either CAPOX or FOLFOX for 4 months, and the chemoradiotherapy was 54 Gray. Patients were restaged at 8 to 12 weeks after completion of the total neoadjuvant treatment and offered wait and watch if they had achieved a complete response or a near complete response. Here are the main results. The 3-year disease-free survival in the induction arm was similar to that of the patients in the consolidation arm, 78% versus 77%. The 3-year metastases-free survival was also similar in the 2 arms, at 81% in the induction arm versus 83% in the consolidation arm. But very excitingly and most importantly, the organ preservation rate was significantly better in patients receiving consolidation chemotherapy after chemoradiotherapy, 43% in the induction arm versus 58% in the consolidation arm. These figures are very, very impressive indeed. So what are the pros and cons of total neoadjuvant treatment? The important pros are that compliance with treatment is substantially better. If you look at patients who have standard treatment, the compliance and application of adjuvant chemotherapy is about 50%. In the trials mentioned above, the compliance with total neoadjuvant treatment was in excess of 80%. There's a decrease in distant metastases. This hasn't yet translated into an improvement in survival, but with mature data, a difference in survival might possibly be demonstrated. There's an opportunity for organ preservation, which is quite important, both in terms of it being an endpoint, but also for our patients, as organ preservation will likely result in a much better quality of life. There are other important advantages. We can study the tumor and its response to treatment. And this approach allows us to perhaps integrate new systemic treatments which might improve response rates and results even further. The main cons are disease progression. Sadly, a small proportion of patients who receive total neoadjuvant treatment might have progressive disease during their treatment, and this will obviously be disappointing. But if this treatment is applied to patients with primarily inoperable disease, we will expect that some patients will have progression during neoadjuvant treatment as it stands at present. This will be a main consideration for patients that have upfront resectable disease. However, with the impressive response rates and the impressive organ preservation rates, it is likely a compromise that we should, as oncologists, be willing to make. The treatment toxicity might sometimes result in delayed surgery or no surgery. We can mitigate this somewhat with careful patient selection, and it's also rather important for all patients receiving fluoropyrimidine chemotherapy to have a DPD deficiency test done prior to application of chemotherapy. We have implemented this throughout the UK, and there's nice guidance on this at present. This has resulted in better compliance with fluoropyrimidine-based chemotherapy and fewer hospital admissions. There are some significant challenges to implementation of total neoadjuvant treatment. The evidence for this treatment is still early. The survival data is immature. There are significant concerns about surgical toxicity. When I spoke to my surgical colleagues about this informally, there were immediate concerns raised about the anastomotic leak rate, which I mentioned earlier. There will also be concerns that the number of patients that eventually have radical surgery will fall, and therefore there will be concerns about surgical numbers. In the UK, surgeons are expected to do a certain number of operations every year to maintain their competence. And if we are decreasing the number by organ preservation, that means that some of our smaller surgical units might be challenged, and as a consequence, this might be a concern for our surgical colleagues. There will always be concerns about disease progression during neoadjuvant treatment. The optimal sequence of treatment has still to be determined. It appears from the OPERA trial that the consolidation approach might be better, and there are resource implications, of course, because there'll be more patients to treat with radiotherapy, more patients to follow up, more demands on our scanning departments. Those are concerns. But we can look ahead with some hope that this will likely become a standard treatment, even though the sequence is still to be determined. And the main reason why it's likely to become a standard treatment is the opportunity of organ preservation. There are other opportunities which we can grasp as oncologists, including an opportunity to study the tumor biology, the opportunity to perhaps integrate immunotherapy, especially for patients with mismatch repair deficiency, and perhaps there might once again be an opportunity to try and look at adjuvant treatment, whether it will add anything at all. I suspect that the gains will be very small, and unless we can come up with a new regimen to include in the adjuvant setting, this will likely not go any further. Thank you very much for your time and your attention. I'll be happy to take any questions during the Q&A session later. Thank you.
Thank you very much, Dr. Correa. for your excellent presentation. That was very informative and comprehensive. We normally do the Q&A immediately after the presentation, so if you're okay, I can, there are some questions presented by the audience. Can I give it to you now?
Yes, of course. Can
Right.
you hear me?
Yeah, I can hear you. First question is, one of the attendees wishes to know how you select patients for this short course or long course chemoradiotherapy in the neoadjuvant setting.
So this particular treatment approach is still just coming to the fore at the moment. We are not using this as a standard treatment as yet. We are in the process of discussing this with our surgical colleagues because as a team we need to be happy to implement this. When we do implement it, it is likely that we will go down the rapido approach with 5 fractions of radiotherapy and consolidation chemotherapy thereafter, but we still have to finalize that. Currently, patients are having long course chemoradiotherapy and then going for surgery after 8 to 12 weeks as standard treatment, and adjuvant chemotherapy after that.
Okay. The next question is, how do you assess after the chemoradiotherapy and total neoadjuvant treatment? Is it by an MRI scan or by a PET CT?
So we, as standard, get an MRI scan of the pelvis at 6 to 7 weeks after completion of treatment. Patients also have a restaging CT scan. And at that point, the scans are discussed with our surgical colleagues and radiologists at the multidisciplinary meeting and proceed to surgery. We don't do a PET scan because there might be false positives or false negatives on PET scan.
Is there a time limit or a time span when you decide when you're going to do this assessment?
So it's usually between 6 and 7 weeks after the completion of the radiotherapy. There is no limit. If someone has nearly achieved a complete response and wants to consider avoiding an operation, then we might offer to do another set of scans at 12 weeks after completion of treatment.
Okay. There is another question. If there is oligometastatic disease, if primary is symptomatic and mets are silent, what will be the best way to handle it?
It depends upon the volume of the metastatic disease. So if the patient has got oligometastatic disease, you presume that the metastasis is small and silent, then it would be reasonable to consider chemoradiotherapy initially. I'm personally prone to giving systemic chemotherapy first, just because if someone has shown the propensity to develop metastasis, then it's better to give them some systemic treatment. So I'd give them 3 months of chemotherapy, and then I'd give them chemoradiotherapy or short course radiotherapy, and then proceed with the surgeries sequentially. If it's a single liver metastasis, then we might use a liver first approach, and then do the primary afterwards, because the primary will take a bit more time to recover from.
Okay, there is another question, Dr. Correa. What is the place for total neoadjuvant therapy for locally recurred rectal cancer who had an AR, anterior resection at primary treatment?
Well, I mean, total neoadjuvant treatment doesn't really apply in that circumstance. You are looking at salvage treatment. And so if someone has had a recurrence, then it depends upon the site of the recurrence and the volume of the recurrence. If it's a very bulky recurrence with lots of vascular invasion, you might want to give the patient some chemotherapy first, followed by consolidation radiotherapy, and then consideration of surgery if that's appropriate, or vice versa. So I think a recurrent situation has to be individualized.
Okay. There is a whole lot of questions coming up. Do you mind? Shall I put them across to you?
No problem at all. I'm
Yeah.
happy to answer as many questions.
Okay. There's another one saying, do you recommend rapido patients with operable liver mets with advanced rectal cancer? Do you recommend rapido treatment protocol for patients with operable liver mets and advanced rectal cancer?
So if the primary is highly symptomatic, then we might use the rapido approach, even though it's. But if the patient is not symptomatic for the primary, then we'd probably go for systemic chemotherapy first.
Such a situation, you might have to go for surgery as well at the end, isn't it?
Oh, for sure. I think surgery is and will for some time yet be the most important treatment for colorectal cancer, be it for primary disease, be it for metastatic disease. We are using oncological treatments as a bridge to getting patients to an operation.
Um, how would you select the appropriate patients regarding neoadjuvant short course and long course radiotherapy? Patients, please share your experience about uh, neoadjuvant short course radiotherapy, neoadjuvant treatment and short
So
course radiotherapy.
So I think you're asking about whether we would give someone short course radiotherapy or whether we'd use long course chemoradiotherapy.
Yeah, I think so.
So we're not we don't tend to give a lot of short course radiotherapy anymore. The evidence was for patients with operable cancers immediately prior to an operation, and we tend not to do that because the surgical techniques have improved so much, and we know that short course radiotherapy primarily reduces local recurrence rate, but we can get extremely low local recurrence rates with good surgery. So we're not using a lot of short course radiotherapy. We mostly use long course chemoradiotherapy where you can achieve quite a lot of downstaging and improve surgical outcomes. So we tend to use more long course chemoradiotherapy. The short course radiotherapy is usually reserved for patients who are frail, who are unsuitable for chemotherapy.
Okay. If after giving total neoadjuvant treatment, if the tumor remains inoperable, then is there any other options that we can think of?
So then the options are you can try second line chemotherapy in the hope that you might get a response with second line chemotherapy, uh, or you can refer the patient to a unit which specializes in exenterative surgery, uh, because they might be able to do something more heroic, including removal of in male patients the bladder, the prostate, maybe parts of the sacrum, high sacrectomies. So that is possible, but it is not a good thing in terms of the natural history of the disease. The patient has not responded to what would be quite aggressive treatment, and I think that the prognosis for those patients will be rather limited, and surgery, while surgery might help, it is unlikely to be curative.
There is another question asking whether you follow patients without doing surgery if there is a complete pathological response, but that was on the trials. Do you do that, Dr.
Uh,
Correa?
yeah, we have started doing that now. So we've got a protocol where patients are having regular flexible sigmoidoscopies, regular MRI scans, and those are very frequent for the first couple of years. So every 3 months in the first year, every 4 months in the second year, and they also have CT scans as well as part of the follow-up, and regular examinations and contact with our surgical colleagues. Most of the patients, if they're going to recur, will recur within the first 12 months, and so I think particularly important to follow up patients in the first 12 months very closely, because if they do recur, then you don't want to miss an opportunity to do a radical operation. But we have started doing that.
All right. Okay. Do you, before you start your neoadjuvant treatment, do you assess the pathological state of the tumor, the histological type, whether it is a grade 3 tumor, a mucinous type, and does that have any effect on your decision?
Currently, it does not change the management. We do look at the pathology, but sub-classification into different variants of adenocarcinoma doesn't make a difference. I'm sure that in the next couple of years that the mismatch repair status, MSI status, will make a difference, because there is going to be thought given to integration of immunotherapy for these patients. But at present, it's not making a difference as yet.
Right. One last question, Dr. Correa, since we are coming, the time is coming to an end. Uh, do you use biological agents like anti-EGFR or whatever in the neoadjuvant setting? Is there a place for that?
No, not unless there is metastatic disease. So if it is localized pelvic disease, we do not use biological agents. We would use anti-EGFR agents if the patients had extensive liver metastasis. I would certainly be concerned about using agents that affect the VEGF pathway, so like bevacizumab, with the primary in situ, because you don't want the patient to suffer a perforation, and that will be, very detrimental to the prognosis. So I'm very hesitant, very cautious with agents like bevacizumab, and certainly no role in the absence of metastatic disease.
Okay. Much, Dr. Correa. That was a very informative and a very comprehensive discussion. Since we are running out of time, I will pass over to Dr. Ari Ratna to continue with the next speaker. Thank you.